is my first time. Thank you, Shada ma'am. And I might be nervous, so please excuse me. Ignore all the stammering and pauses. So I'll be speaking on rubella screening in pregnancy. In India, around 40% of childbearing age group females are susceptible to rubella infection. It is very important to know the rubella immune status of the patient before she embarks on pregnancy, because rubella infection in pregnancy is a very serious threat to the newborn. Rubella virus is also known as German measles or 3-day measles infection. It is highly contagious. It's a single strand RNA virus belonging to Toga family, and it's highly contagious. The modes of transmission are direct contact with the secretions, aerosol transmission through droplets or aerosol which are produced by coughing, sneezing or talking, and the most important about which we are concerned is the transplacental transmission. The incubation period is around 14 to 21 days. This is the slide on mode of transmission: direct contact, airborne and transplacental. So it is highly contagious just 1 week before the onset of rash and around 4 days after the onset of rash. Why is screening required? Screening is required because once a patient gets infected, it leads to very hazardous implications on the fetus. There are a lot of malformations, like there is a triad of malformations: cataract, deafness, sensory neuronal deafness, and cardiac defects, of which patent ductus arteriosus is the most common. Rubella infection, if it occurs in first trimester, it leads to abnormalities in around 85% cases, babies. In second trimester, the infection leads to defects in 16%, and if the infection takes place after 20 weeks, then the fetal defects are not very common, but she might land up with a growth retarded baby or a stillbirth. This is the congenital manifestations. The classical triad is deafness, blindness and heart defects. So why is the screening to be done? Rubella is a very mild disease. One might, if the patient just complains of cold and cough, one might miss the signs and symptoms and take it as a normal cold and cough. And the rash is usually not visible in Indians because we are usually dark colored. So if a patient is complaining of mild cough and cold, she is to be investigated, because infection with rubella leads to very hazardous effects on the baby. The recommendations by FOGSI are like the patient should be screened before pregnancy and during pregnancy. Before pregnancy is all the childbearing age women should, the screening is recommended. Both IgG and IgM should be tested. In case both turn out to be negative, we should vaccinate with MMR. The rubella component in MMR vaccine is the protective vaccine. MMR is recommended. In immunization program, Mission Indradhanush, MMR is recommended. So in first trimester of pregnancy, it is FOGSI recommends screening with IgG titers. And if the patient is giving a history of contact with another patient who has a similar sort of illness, or the patient is having rash along with signs and symptoms suggestive of cold and cough or viral, so we do an additional IgM screening in that patient. So a word about how the immunity develops in rubella. Initially the patient gets infected, and after 10 days of onset of infection, the patient IgM antibodies start appearing. The IgM antibodies are visible around 3 days after the development of rash, and they start peaking and around 4 weeks of after onset of infection, and they disappear by 12 weeks of onset of infection. And IgG antibodies, they usually start being detected after 10 days of onset of infection, and they peak around 3 months, and then they persist lifelong. Now this is the screening. Initially when the patient comes in first trimester, we do an IgG test. In case it is positive and the patient is not having any signs and symptoms, then we have nothing to worry, because she is most probably immune. Either she is immune from the past infection or a remote infection, or she has had a vaccination done. So that is why screening is important. We have to know whether she has a vaccination done, whether she is immune, or she is a susceptible patient. In case the patient is having some signs and symptoms of viral infection, then we go for avidity index. And what is avidity? Avidity is the strength by which the antigen binds to the antibody. As the immune response matures, the avidity index rises. Initially, we have low avidity antibodies in the blood, which later on, after maturation during the maturation, these low avidity antibodies are replaced by high avidity antibodies. And this transformation takes at around 3 months of post-infection. So in case IgG is negative, we do an IgM titer. In case IgM titer is negative, then there can be two scenarios. Since IgG is also negative and IM is also negative, either the patient is not having any infection. If she is not having an infection, that means she might be susceptible to rubella. So we have to vaccinate her after delivery. Another scenario is if IgM is positive, IgG is negative and IgM is positive. That means there are two scenarios. Either the patient has had a recent infection, that is less than 10 days of onset of infection, and so we have to rescan, we have to repeat the serology after 3 weeks and document the increasing trend in IgG titer, or the IgM might become positive then. Another thing is if the IgG is negative and IgM is positive, that means the patient is having a recent infection. She is suffering from maternal rubella syndrome. And this is just a screening test, then we'll diagnose later on. And if IgM might be false positive as well in some patients with rheumatoid factor, or if infection with other viruses like parvovirus or some, so in that cases also IgM is false positive. Now avidity index, the relevance of IgG is the good antibody, and avidity index, by doing it, in case it comes to be high or low. If it's high, that means it's an old infection, because the immune response has matured and we have high avidity antibodies circulating in the serum blood. And in case the avidity index is low, that means the immune response is maturing, it is developing, the patient has had a recent infection, and eventually it will transform into a full-blown mature response with high avidity antibodies. This is a sample report of the rubella avidity which we get from the Lal's Path Lab. The cutoffs are less than 30% is low avidity and more than 40% is high avidity. 30 to 40 is equivocal avidity. CDC recommends that we test for IgM as well as IgG at the time of the first visit. So to summarize, again this is just a tabulated form of the previous slide I had shown. In case rubella IgG is positive and rubella IgM is negative, the patient is either immune to the rubella due to some remote infection or vaccination, and nothing is to be done. There is no risk, the patient is not susceptible. Another case is when rubella is IgG negative, the patient is IgG negative. We say negative when the antibodies levels are less than 10 international units per ml. And even IgM is negative, that is the levels are less than 0.9 international units per ml. Now, in that case, the patient is either not infected, first of all. If she is not infected and she is susceptible, then we have to vaccinate her postpartum. Or she is having a recent infection, and so we have to repeat the serology after 3 weeks to see for the seroconversion. Third scenario is when IgG is negative and IgM is positive, that indicates that she is having a recent infection, or it might be a false positive. So we have to repeat serology after 3 weeks. Last and the best seen is that if IgG is positive as well as IgM is positive, then we go for avidity index. In case it is low, that means it is an acute onset infection. In case it is high, it means a remote infection. So after screening, what is to be done? We have screened, and in case we are suspecting the patient to be suffering from rubella infection, then the diagnosis is made either by demonstrating rubella specific IgM antibodies or a 4-fold increase in IgG titer, which is repeated after 3 weeks, or a positive culture. And then we counsel the patient that this is just a screening test. Diagnosis can be done by these demonstration of 4-fold rise in the Ig titer or culture. Then in case the patient wants to continue pregnancy, then we offer a confirmation test by offering blood or amniotic fluid for RT-PCR to diagnose perinatal infection. So to prevent, there is no specific treatment for congenital rubella syndrome. It can only be prevented by vaccination, and that too by MMR vaccination. Government of India has launched a intensified version of Mission Indradhanush, in which the aim is to vaccinate around 95% of child reproductive age group females with 2 doses of MR. So the polio has gone. Now it's a time to eliminate measles and rubella. Thank you.